Welcome to the Expand Your Digital Knowledge with the iTero Element. It is a webinar being presented by Kelly Bevington, RDA EFDA, and Brittany Carey, RDH. Today's session is iTero Element, taking your skills to the next level. And with that, it is my pleasure to introduce one of two. First, it's Kelly Bevington, RDA EFDA. She is the Director of Intraoral Technology. Kelly began her career more than 20 years ago as an RDA EFDA, graduating from Bryman College. She has a comprehensive knowledge of dentistry and the dental laboratory industry. Kelly has been professionally trained on most major devices, and she is able to provide expert chairside coaching. She manages the NDX Clinical iOS training team and has clinically trained over 1,000 dentists and their teams. Kelly enjoys sharing her knowledge by presenting webinars and is a regular contributor to dental publications. And Brittany Carey, RDH. She is an iOS clinical training specialist. Brittany is a registered dental hygienist with clinical experience working within the areas of periodontics, pediodontics, and general dentistry. She joins us with an intraoral scanner training background, having collaborated with colleagues at Align Technology to target and train DSOs and private dental practices. Brittany has a passion for training and education, the ultimate goal being to create success for every dental team member. Brittany resides in Phoenix, Arizona. However, tonight she's hailing from Southern California. And now it is my pleasure to say, take it away, ladies.
Thanks so much, Jessica. Really appreciate the kind words and introduction. And I would like to reiterate to all the attendees, thank you so much for being here. It really means a lot to Brittany and I that you are choosing to spend some time this evening with us remotely learning about iTero scanning. So we do have an amazing team scattered across the country. So I happen to have the honor and privilege of managing the team. I reside in Pittsburgh, Pennsylvania. And then we have Kelly Lipthrot. Kelly is in the Southeast, residing in the state of Florida. Then we've got Brittany, as you have just met. Brittany is in Arizona and covers the West. Brenda Kirkin is out of Michigan, and she covers sort of the Midwest. And then we've got Bannister Poe. Bannister is in New Jersey, and he covers the Northeast primarily. We all have slightly different skill sets and levels of expertise on different scanners. So we don't have hard defined like territory lines. We're not selling devices. We are clinical dental professionals. Myself as a RDA EFTA, Kelly is a registered dental hygienist, as well as a certified dental assistant. Brittany is a registered dental hygienist. Brenda is a CDA RDA, and Ben was trained in the Philippines to be a dentist. So we all speak the language and enjoy sharing our knowledge about iOS and how it relates to dentistry.
Perfect.
Thanks.
Thank you. All right. Please let me know if my volume is okay. I'm dealing with hotel internet here, so just let me know if I'm wigging out.
So far, so good. Thumbs up.
Okay, good. So a lot of this presentation, or some of this presentation tonight, is going to be a bit of a refresher of things that we covered in part 1 of this series. For those that may have missed it, we do want to make sure that the back to basics bases, so to speak, are covered so that we can have a successful scanning experience for both clinicians and patients. As we all know, hopefully by now, that we can basically scan for practically anything. Tonight, the focus is going to be on scanning for a bridge. However, you can scan for implants, abutments and crowns, removables, partial dentures, surgical guides, bite splints, orthodontics, and sleep appliances. The intraoral scanning best practices, we did hand this out in part 1, and I believe we're handing it out again this time with some additional resources as far as scanning. But again, this is just really important back to basics information for anyone that could use a refresher or is new to scanning. So of course, we have to mention that a supragingival finish line is preferred. However, if sub G, in order to achieve apical and lateral gingival tissue retraction, it is required to expose the margin in order for the scanner to obtain the data. Keyword here being required in order to expose the margin. This can be accomplished with retraction cord, retraction paste, or in some cases laser. And please feel free to ask any questions in the chat or the Q&A box, and we will answer them as we go along. We just got some screenshots here of the workflow when we're getting ready to scan for a bridge. So we would hit new scan. And this is just pointing out here that iTero did roll out a brand new RX. So your scanner may still have this purple banner, or it may not, just to let you know that it's there. If you were to click on the purple banner, it's going to pop up a QR code, which I have on the next slide, with training resources on the new RX. So we do recommend that you look into that so that you are completely familiar with all of the new things that they've implemented and all that good stuff. So I'll just kind of pause here for just a moment if anyone wants to take a screenshot or photo.
And you can share that link. So once you take a scan of the QR code, you could share it with everybody in your office on your team as well.
Right. Mm-hmm. Cool. All right, I'm going to go ahead and move forward. We did want to highlight something pretty cool that they did implement with this new updated RX is you can now select materials and favorite them so that they will appear at the top of your selection screen. So all you would do is just hit the star, and then you would hit the done button down below to save it. So as soon as you go back into your material selection, you'll see that your options that you favorited are at the top. And I love that they added other, because maybe your selection is not there, your material. So it says check note. So I just love that, because we encourage everyone to put as much information for the lab as possible in the notes section. So let's go ahead.
I'm going to try to do that live, actually. So.
Okay, perfect. Let's go ahead and we're going to chart for a bridge. So we selected fixed restorative for this procedure. Oops. So we're going to start off by just selecting what tooth we're going to start with. And I'm going to highlight, oops, my gosh. I'm going to highlight bridge here, even though we have a plethora of things to choose from. The first thing we want to do when the next page appears is define our bridge, the teeth that are part of the bridge. So in this particular instance, it was a bridge 29 through 31. When you select just one tooth, you're going to have these options to choose from. So tonight we're going to select abutment. However, if it were an implant, you would select implant based to get into that menu. Now again, we can still see that this tooth 29 is highlighted. We do recommend that you fill out each individual tooth's RX before you move to the next tooth, before you go to the next tooth. So we're going to fill out the specification. We're going to select our material. And I do want to highlight here that this additional information optional bar will be closed. So I wanted to highlight here that when I opened it up, you have the option to select your prep design from the buccal and lingual aspects, but also, this is cool, margin design. So you have these options to choose from. And this is something you would have put in the notes section. So instead of having to type that in, now you can just select it. And of course, we can't forget the shade. We love, love, love knowing what shade. So next we're going to select the next tooth, number 30. We're going to select Pontic. So you'll see here that now it looks like a missing Pontic, but we can tell that tooth 30 is highlighted in white. I just wanted to point out here again that there's that additional information bar that you can collapse and reopen. But they also added this as part of the new RX, which is the Pontic designs that we'll go over here in just a second. So if you put your finger on the dot for each one, it should appear down below here, right here, the name of each of the Pontic types. So we've got the Ridge Lap Pontic, we've got the modified Ridge Lap Pontic, we've got the Stein Pontic, the Sanitary Pontic, and the Ubalti Pontic. So that's pretty cool. So you can see I did not take any screenshots of tooth number 31, only because it would just be kind of duplicating what we just talked about. But as soon as you're done filling out the RX for each individual tooth of the bridge, you're gonna come back to the main screen. It's gonna look like this. And then of course down below here is the notes section that you would add your other material had you chosen another material. Are there any questions so far, Kelly? I just want to make sure I'm not just flying through this.
No, I don't see any. I do want to add though to the Pontics that we talked about, that if your Pontic isn't listed or it's listed in a slightly different fashion, just put that in the notes. Like I'm accustomed to requesting a hygienic Pontic and it's not on there. So, and the last one, I'm thinking maybe it's a typo. Like I'm accustomed to seeing ovate, OVATE, but maybe not. So, this is for the whole world, not just North America, the United States. So if your name isn't listed, please put it in the notes.
Good call. Now the iTero specifically has its own scan path protocol, which is occlusal lingual buccal, or OLB, as we will refer to it. And it was designed specifically to make scanning efficient and fast. So as long as we are scanning using the same scan path protocol, occlusal lingual buccal for each segment, we can scan really quick. So this is just a screenshot here of once we hit the scanner icon, we are now in the scanning phase. And I wanted to point out here that this box is displaying because we enabled the guidance hints in the scanner settings. So if you have any questions about that, maybe Kelly can show us again how to do that. But for each scanning segment, it's going to show us a visual of what we're trying to accomplish in this particular segment highlighted, and then also some tips and tricks on what kind of data we're looking for that particular segment. Now, because we should be scanning the preps first, because that's when they're the cleanest, the clearest, and driest, and we can control everything from that point. Here's some tips that we will kind of do a refresher on. The great thing about the iTero scanner is that before we even activate the wand, before we turn the wand on, we want to place the scanner inside the mouth, and we want to be focusing on the viewfinder window on the scanner itself to make sure that we are, the scanner's looking at exactly what we're trying to scan. So because we're trying to scan just the prep right now in this particular image, we're scanning prep tooth number 19. We want to make sure that if we feel that angulation may be an issue, we can practice getting that angulation before we even turn the scanner on and start capturing data. So when we're finally ready, we're going to activate the wand. We're going to scan occlusal lingual buccal, OLB. Fun fact, the contact walls of the adjacent teeth are not to be captured in the scan. Not saying you can't capture them. If you capture them, that's fine. But the prep segment is solely for the prep. We're going to capture the adjacent contacts in the prep arch segment, which we will get to shortly. Once we're done scanning occlusal lingual buccal, we're going to turn the wand off in order to analyze our prep scan. If we have any voids of missing data, we're going to utilize the fill tool, which we'll talk about here in a sec, to capture any missing data. And then before we continue on to the next scanning segment, we want to make sure that the green dot is put into the center of the prep. And that comes into play under post-processing, and Kelly will demonstrate that for us. So just a quick reminder, in order to not overscan, we want to make sure that we're not scanning the prep longer than 9 seconds. And these images are wonderful at demonstrating that, the reason behind that, actually. So we can see here, we've got a clean, clear margin. We can see some fluid building, but we've got a clean, clear margin at 5 seconds in. And then at 13 seconds, we can see that the margin is completely obstructed by moisture. So being fast is key. Now let's talk about some corrective action tools while we're still in the scanning phase. And these should be utilized as soon as we're done scanning each segment. So we're going to press and hold on the screen, and this little menu is going to pop up. Segment will erase the entire scan of that segment. Selection, I don't bother using personally because you can sweep away to delete data, but I always sweep away the good stuff too, so I don't even touch it. But I do want to highlight here the fill tool. The fill tool is our best friend. It allows us to scan areas of missing data without overscanning, without compromising the good part of the scan that we've already captured. Now this visual here is just to show you, like for instance here, we've got a void, we can see the background through the tooth, so we know that we've got some missing information. Once we activate fill, the only way to know that fill has been activated is if we see the areas of missing data circled in red, so highlighted in red. Sometimes fill will shut off because it feels like it sometimes, I guess. So we do want to be sure that before we turn the scanner on to fill those voids, that fill tool is actually enabled and on, so that we're not just adding additional layers to the rest of the scan.
I believe it times out, Brittany. I think it's like 8 to 10 seconds you have before those red circles disappear.
Yeah. Now we do recommend that you follow the arrow prompts when scanning the segments, at least until you are comfortable using the iTero. And that is because with the iTero, if you were to scan something under the wrong segment, you cannot like switch that around. Unfortunately, you would have to erase it all and do it all over again. So to avoid that, if we're using the arrow prompts, then we've got, our eyes are right here reminding us, what we're trying to focus on for that segment. And I wanted to highlight here, because this is the prep arch segment, it's reminding us occlusal lingual buccal, right? But it also has here, I want to capture here, capture the contacts of the adjacent to the preps. And then next, it's going to ask us to scan the opposing, again, occlusal lingual buccal, and finally capturing the bite. And it is reminding us that we want the patient to be biting in centric occlusion, of course. Now let's talk about some things that may happen occasionally from time to time. Sometimes we miss scan segments. Sometimes the software has an issue stitching segments because there's not enough data that was captured. So we'll get, when we try to hit the post-processing icon to move forward, we'll get an error or a warning rather that tells us that, something is wrong, something's missing. Our options are either to return to scanning or to ignore. Please don't ignore. Please just stop, take a breath, and read the screen and just, last thing we want for any of our offices is to send an incomplete scan. So what's kind of cool is if you return to scanning, it's going to show you in red the area that was either missed or the area that needs more data. Now, once we get into post-processing, once we've scanned all of our segments and the scanner is going to stitch all of it together, we want to evaluate the digital bite. And we, of course, this is where we verify that the patient was in centric occlusion when we captured it, because we have to remember that just because the scanner can put the bite together does not mean that that is the patient's true bite. Okay. So again, we're still under post-processing. This is where we're going to evaluate our scan. And of course, we care about the preps. The prep's the most important part of scanning, right? So we're going to view the prep scan in high resolution by tapping on the prep separation icon, aka the dye separation icon, which is highlighted here. And when we select it, we're going to rotate the model 360 degrees. And then we've got the checklist, which I think is also here. Yeah. So this is what it's going to look like. As soon as we hit the prep separation icon, it's going to turn into two different icons, one with a plus sign, one with a minus sign. The plus will extend the prep area. We will add information to it. And then the minus sign will take away data. So what we want, and this is where the green dot comes into play, is as long as we put the green dot in the center of the prep, it should only highlight just the prep in gold like this. If not, we want to make sure that we either add information, or if it's focusing on an adjacent tooth or something, we want to take that away so that in high definition, we only have the prep. The occlusal clearance map is great, and it's located right here. We can turn it on and off with this icon. If we see red, it's just like a weather map. Red is not so great. We don't want to see that. And this actually goes off of the material that was chosen in the RX. So that's something to keep in mind as well. So I'm going to show you guys what may happen sometimes if we see red on the occlusal clearance map, and we need to, do some reduction on the prep. These are the steps that we're going to follow in order to do that. So we're still under post-processing. And I want to highlight here the eraser tool. And once you click on the eraser tool, it's going to open up into these three icons. It's the undo button, which is awesome, the eraser tool, and then a scanning icon or a scanner icon. So the first step is to, of course, rotate the model to ensure that you are looking at the prep from the buccal view. And then you can hit the eraser tool. We're going to circle just like the top half of the prep. We are going to adjust the clearance on the prep tooth, and then when we're ready to rescan the new occlusal surface, we're going to hit this scanner icon here next to the eraser tool, not up here, just down here. So it actually brings us back to the scanning phase, and it's kind of like the fill tool, where it's gonna highlight the area just like the fill tool would. And again, we want to make sure that we are showing the lens occlusal, lingual, buccal, because we want to make sure that we're capturing the new height of the prep, and we're not going to be able to capture that only from the occlusal surface, if that makes sense. And once we're done with that, we can hit post-processing icon at the top again for the software to reanalyze. And then we want to confirm, of course, that there was enough reduction. And if they're still showing some red, you can just repeat the steps if necessary. Prior to dismissing your patient, these are the things we want to be sure of with all of the scan segments. With the opposing arch, we want to confirm that there's enough anatomy because the occlusal and buccal surfaces are key to ensuring a proper bite registration. The prep arch segment, of course, we want a defined margin clear of overlapping tissue or any other obstruction, whether it be moisture or cord, and that we fully captured the prep tooth. Prep segment, oh my gosh, that was for the prep, I'm so sorry. So under the prep arch, we want to make sure that there's a solid mesial and distal contacts of the adjacent teeth, and then of course enough occlusal and buccal anatomy for the bite. And for the bite, ensure that the scanned patient registration matches the patient's actual occlusion. Super important. And then we of course want to make sure that the prescription is complete, that we've put in any shade or material or anything in the notes that would benefit the lab, communicating to the lab. They greatly appreciate communication. And that's all I've got.
All right.
But here's where you can reach us if you guys are interested in, scheduling us for your offices or doing remote trainings or things like that. We've got digital impression at nationaldentex.com. You can email us, or you can give us a call at 1-800-511-7147.
Thanks, Brittany. We had, I'm just reading in the chat real quick. So we have an attendee that's having an issue with their audio, and Jessica is helping them troubleshoot that. But while that's happening, is anybody else having issue with their audio? If you want to respond in the chat, if you are. No. Okay. I'll take that one no. I'll take that two no. All right. I'm going to go ahead and share my screen now. And I am logged into my iTero scanner here in my office. And we'll do a demo. Let's see here. Woo. Close some of this up. And are you able to see like the full screen of the iTero?
Yes.
There we go. I think that's better. And I just want to do is it the annotate? Why do I always forget this? I want you to be able to see my cursor. So can you see my cursor?
Yes, I can.
All right. And as we're doing this, just let me know if there's any particular questions.
Perfect.
Okay.
Will do.
Super. So I am going to set up a new scan, right? And I really don't like to do it on the computer. I guess I could, but I'm gonna diminish my video for a moment. Super. Okay. One thing that Brittany mentioned earlier is the settings and the guidance hints. So I wanted to alert you of the guidance hints and where you can locate those. Okay, so the guidance hints are going to be under the setting. And from settings, you're going to go to scan settings. And then you will see enable guidance hints right here. I have mine currently enabled, and I highly recommend to keep that, especially if you have any newer team members as part of your practice. In the event you ever need remote access assistance from one of us, you're going to tap on the green question mark you would call us first, tap on the green question mark, and then we'll walk you through how to access Team Viewer. So from here, I'm going to go to New Scan. And Brittany, are there any particular questions, comments, or concerns?
Nope, I did get one question about how much an iTero scanner is, but I'm responding to that right now.
Okay, super. Okay, so we've got, again, this is the new RX. So we really wanted to take a little bit of time and walk everybody through the new RX because it just launched about 4 weeks ago, just last month. So under procedure type for a bridge, we're going to select fixed restorative. And then we're going to select our laboratory and NDX lab, of course, right? In this particular demonstration, I'm going to select a pre-treatment scan, and I just have, obviously it's a type it on, right? I don't have a patient here, but I have just like a little mock piece of silly putty that I'm going to put over top of the bridge prep. So that's going to represent the before of broken down teeth, if you will. Now, the thing about the pre-treatment scan, and right here is the pre-treatment scan, right? It has to be selected now. It has to be selected when you're filling out the prescription. It cannot be added to after you've already started scanning. So I'm tapping on pre-treatment and selecting that. And then the tooth numbers that I'm working with for my bridge are 19, 20, and 21. So as I select 19, I want to show you something, right? Because if I just select 19 as regular and then 20 as my Pontic, actually, I can do bridge here, right? And then I can tap on the Pontic and make it truly a Pontic. And then if I select 21 and make it a bridge, I did this by accident earlier and I thought it was really cool. I wanted to show you. Now I'm duplicating it. So it's 19 to 21. Oh, there we go. So if you select regular by accident, you're going to get this red alert. Can you see it on your screen that said that a regular cannot be part of a bridge?
It did show up. Yeah.
Did
we
it show
saw that.
up? Okay.
Yeah.
Okay. The Pontic, and then I've got my abutment and my abutment. And my specification, I'm going to do full contour. And I'm going to add a favorite. And my favorite is going to be ceramic zirconia. So that's the example as to how it happens live. And then you select done. And that's it. Super. So we have our bridge, abutment is 19, Pontic is 20, and second abutment is 21. And now we're going to go, and I do have pre-treatment selected. So I'm going to get my silly putty. And I'm going to go to scanning. You don't have to do a pre-treatment when you're doing a bridge, but I think it's helpful if the teeth aren't too broken down. Anytime you're doing a pre-treatment scan, it's allowing an additional level of communication to the lab, right? So even if the teeth are broken down, the lab is seeing how that tooth grew right out of the tissue, and that can be very helpful to them for the design. So you'll notice it says lower one and that the background is actually green. So when the background is green, you're in pre-treatment. If it's blue, you're in active operative scanning at that point. So this is pre-treatment, and this is going to be, I'm going to do a full arch because I also want to demonstrate to you just a little tip on how to acquire full arch data and a little change in your hand positioning that you may find to be helpful. So I typically start on the patient side that restoration is going to be. So in this case, it's going to be the left. I'm going to start on the occlusal of, in this case, it's a third molar. And I've got all my occlusals. Here's my silly putty mock-up. Those are my broken down teeth. Got all my occlusals coming along. That's my implant for our next presentation. And then I'm going to wrap lingually. And wrapping around to the buccal. So notice, as I'm coming across the buccal, it's imperative that you capture a good 2 to 4 millimeters of gingival tissue below the CEJ or the cervical crown portion of the tooth. Now, when I get to the midline, and I think you can see my hands as well. When I get to the midline, I'm going to take the wand out of the patient's mouth, come in on the opposite side, and then rotate buccally to capture that data. And the reason I do that is it becomes a little awkward when I get to the midline, and this allows me to steady things up. And then when I get to the anterior, I want to make sure that I'm coming and sort of tagging up along those incisal edges, cuspid to cuspid, because that's a common area of error. Just want to make sure I have all the occlusal in my pre-treatment that we see with data, right? Or their lack of. Super. So I'm going to turn it off. This is my pre-treatment scan. And now I'm going to use the arrow to advance to the next screen. And that's going to be the upper. So again, like habits that you're creating, anytime you start on one side on one arch, I like to start on that same side on the opposing arch. So for the upper, which is the opposing, I'm also going to start on the left. And it's going to be occlusal. I know everybody will be so sick of hearing occlusal lingual buccal by the end of the session. But it's repetition, you know, we say it all day, and it hits home after a while. It really makes a tremendous difference in following a proper scan PAP strategy. Here's another little tip. When you are rotating on the occlusal of that second molar, you can drop the tail of the wand a little bit to get the distal of that second molar, and ask your patient to relax their jaw and shift to, in this case, would be to the right, to allow you to capture all of that data, right? That's oftentimes a difficult spot for us to capture. Again, remembering on the opposing, we still want to capture that 2 to 4 millimeters of gingival tissue. And I'm at the midline, it's getting a little awkward again. So I'm taking the wand out of the patient's mouth. I'm inserting it on the opposite molar. I'm going to capture this molar as well. And please know that the distal of those second molars are not mandatory data for full arch opposing for a bridge, right? I just did that for demonstration. See how that's dark on the incisal edge? That's what I'm trying to correct and remove to ensure that that full arch scan is being completely captured and merged both lingually and buccally. Very, very important with full arch scan. So now I'm turning the wand off again, and I am using my arrows to advance to the next screen. And this is our guidance tip hint that is encouraging you to scan with the patient in centric occlusion. I like to, whether I'm standing or sitting when I'm scanning my operative arches, I don't necessarily have a preference to instruct you one way or the other. However, when I get to the bite registration, I am for sure going to sit the patient up. Think about it, you know, just put yourself in their shoes, right? They've been anesthetized, they've been upside down on their head for a half an hour, and we're asking them to bite normally. And it's like, I mean, it just seems sort of silly when we think of it that way. So have them sit up, you know, rub their temporomandibular joints a little bit, have them open and close a couple times. It's our responsibility as the dental professional to know what their normal bite was before we ever started to scan, before we ever start to prepare their teeth. So when you do the pre-treatment, they might be anesthetized, but they haven't been prepped yet, and the likelihood of getting a more accurate bite is higher. The offset of that is you have to pay really close attention to the lens of the wand. It has to be clean and clear when you go to do your preparation scan, which will be next. So bite registration. I'm done with my rant of bite registration. I'm always going to take my bite in the premolar area. It's not necessary to go the whole way back to the second molar. And if anything, it's uncomfortable for the patient. Remember, with iTero, you need to be touching the tooth surface. So when you're trying to touch the tooth surface, if they've got, you know, a buccal tori or something and you're scraping against it, they wince ever so slightly. You don't really notice it when you're taking, I mean, I've instructed and scanned myself thousands of times, and you really don't notice that just slight little open, and it can make a huge difference at the laboratory. So I am having the patient open, I'm inserting the wand, retracting the cheek. I'm going to have my patient close. There's my little silly putty mock-up. And I'm starting where the teeth interdigitate. I'm going to go up to the maxilla, and I'm going to go down to the mandible, and then I'm going to start to pull out and turn the wand off. Now, that purple on occasion will show up down at the bottom of the screen. And if it does, take a big deep breath, count to 3, and 90% of the time it pops into the articulated arches. Years ago, I was rather impatient, and I would see the purple at the bottom, and I delete it right away and start again, and delete it right away and start again. And so I learned the hard way. I like to share those learning experiences with the attendees from the webinar. So now I am going to do the second bite on the other side. And pull out. And we're confirming we've got it interdigitated here, and it looks good there. And so now we're advancing to the next screen. And the advancement of the next screen is going to be for tooth number 19. So I'm going to take my silly putty off. Voila, I have a bridge preparation, right? So I'm going to start with 19. I'm lining up those green crosshairs, and they're right over top of the occlusal, right? Right over top of the occlusal. Can you see that there? Right, super important. And notice I'm using 2 hands, right? Super, super important for ergonomics. It's recommended by Align Technologies, by iTero, to position yourself at a 12 o'clock position, which I pretty much am now. And I'm going to line up these green crosshairs, and I'm going to turn the wand on. So as I'm scanning, I'm rotating lingually, and I'm rotating really to be very parallel to the lingual surface of that prep. And I'm rotating over to the buccal. And I'm sort of doing like a 2 count in my head. 1, 2, 1, 2. And then I'm going to drop the tail of the wand just a little bit to get that mesial wall. At which point, I'm going to take my green dot and I'm going to position it right over the prep itself. Okay. So I'm going to advance to the next section, and that is going to be for tooth number 21. Same thing. I am positioning those green crosshairs right over top of the occlusal. And it's occlusal, fully rotating lingually. And that's what we talk about, angulation. And I like to, and I'm fully rotating buccally. And then I'm going to come back and make sure that I have that mesial wall there. So we talk about angulation frequently. I'm going to take my green dot and position it right over the occlusal. So with angulation, when you first turn on your scanner, you can really capture your entire, the view of the entire prep from the occlusal in like 2 seconds. But that's not an appropriate scan. The appropriate scan is really to fully rotate that wand so that it's parallel to the lingual surface, and then over the occlusal so it's parallel to the buccal surface. And why that's critically important is from the lab's perspective, then you're getting all of the angulations of the prep itself. One of the iTero training managers uses an analogy that I absolutely love. Think of angulation, right? Like most of us have some sort of a cell phone now, and we will take a selfie from time to time of ourselves. Now, if I take a selfie and my phone is up here, usually my image is, it's me, right? It's okay, it's good. But if I take it from down here, it's like all of a sudden I look like Jabba the Hutt, I've got like 4 chins. So think of all the angulations of the prep and how important that is to capture it. So now we are doing our last scan, and this is the second lower scan. This is where I will make sure that the interproximal contact walls for 21 and 19 are also captured. So we're doing those occlusals. Got to dip in, make sure I get that wall. Going lingually. We're not paying a lot of attention to the prep, right? Because we've already captured the prep itself. Getting a little awkward there at the midline, so I'm going to come in on the other side. And then cross it over. So I'm going to turn it off. And now I'm going to confirm that I have the contact walls of 22 and 18. So I could get a little more there, right? And that one looks good. So I'm going to activate the fill tool. And I encourage anybody that has a question to ask that question. I'm in post-processing now. So anyone that it actively uses a scanner will know that post-processing for full arches do take a little bit longer. I thought it was worth the risk-benefit ratio that there's benefit in experiencing this. So how are we with comments or questions, Brittany?
We're good. No questions just yet.
Okay. It's a quiet crew.
Or are we just so great at explaining these processes?
I don't know. Is everyone still there? I can't see. I hope so. I hope you're sticking with.
It's not just you and me. Oh, we did have a question just now. Mary says, I have only had my machine a week. How do you move the green dot?
Oh, you press it and hold it and move it. You drag it. Okay, so this is what times out. So I am gonna get in here sort of quickly and capture that. And if there's anything else that's missing that is impactful to the fabrication of the crown, you could take that then. And although we are perfectionists, I think by nature, and do that last post process, know that, you know, the interproximal data of an anterior tooth, if you miss it, that's not impactful to the fabrication of the bridge on 19, 20, and 21. Does that make sense? Like, yeah. Don't get so worked up that every little speck of data has to be captured on, on an opposing, for instance. You have to capture all the occlusal data. Absolutely, that's the biting surface. And you must capture 2 to 4 millimeters of gingival tissue. That's critically important for the bite registration. But little interproximal areas, especially if there's some severe crowding, is not impactful to the fabrication for a crown or a bridge. It would absolutely be required information to acquire, though, if it was like for a retainer or any type of Invisalign aligners. This should be my last post-process.
We got some compliments. We're doing great.
Oh, good.
Everyone's just processing all of the information. Oh, we did get one more question.
Sure.
Really, can you repeat the tip you gave about what to do when you see the purple area when doing a scan instead of starting over? The
purple area, meaning the bite registration?
I believe so.
Okay. So sometimes your bite registration, I know I'm not on the bite registration page, right? But let me go to the bite for a second. Okay, so if you're here, right, on occasion, your bite registration will show up in the center at the bottom of the screen. It's like the maxillary and mandibular arches are modeling. It sort of appears as though they've come together, but your purple confirmation is down in the bottom center of the screen. My tip is to take a big deep breath and be patient, like count to 3, and 90% of the time, that little purple in the bottom of the screen will go up to the modeling that is being created. It just is taking a moment for the computer to process that data. And what I had shared was that years ago, I tend to be a rather impatient human being. Years ago, I would see the purple at the bottom of the screen and immediately delete it and start again, and delete it and start again. And it was like, wait a minute. You know, I attended continuing education courses. All of us attend constant continuing education courses annually with the different scanner manufacturers to ensure that we are providing you the most up-to-date information. I hope that answered your question. Okay, so
Oh, really quick, Kelly, before we move on, another question about the bite. When I take a bite, I always get an error saying I did not scan both sides when I did. Any tips?
yeah,
And actually,
so,
go ahead.
No, you first.
Well, I was just going to say I had this happen just last week in an office. And what ended up happening is the clinician scanned one half of the bite for half the mouth and left the wand on when they went to scan the opposite side. And what you have to do is actually you scan one half of the mouth for the bite, turn the wand off, place the wand on the opposite side, and turn the wand back on to capture the second
Absolutely. And I think that's people's most common error is they don't turn it off in between sides, right? So you're going to scan the right side, turn it off, then insert it back in and turn it back on. The other thing that could happen is the patient could have winced, they could have moved, or the first bite that you took was not accurate. What it's telling you is that the two different sides are not matching. That's what it's trying to tell you. So the troubleshooting part of that could be to delete the first bite and rescan it. It could have been the very first bite that was just not right. The great thing is that with digital technology, it's you delete it. It's not having to get your blue moose back out again. So that part is awesome. Oh yeah, I like the little thumbs up. Very cool.
Oh yeah, is that cool? We do have a couple other questions too.
Yeah.
Let's see. I want to get them in the order we received them. I have a preparation at or above gingiva, giving me much better perio response. Is packing cord necessary? And you, Kelly, at Dr. Martin's office did great.
Oh, thank you. That's very kind of you. Is it necessary? I guess necessary is a key word, right? You may very well be able to get a nice clear scan. So as an example, right? Like, what is a clear scan? You want to always be able to go from color to monochromatic or stone model mode. And I know these are type-it-ons, right? I get that. But you want to be able to see a nice crisp margin, 360 degrees. And sometimes, even if it's a single 000 cord, provides enough lateral retraction of that gingival tissue so that the lab technician can see, oh, okay, this is clearly still enamel. And here is where the prep is when it's supragingival. But if you can change it to monochromatic and you can see it very nice and crisp, then you should be fine. I don't think you need to do additional gingival tissue retraction if it's supragingival. It's it's right when it's at the gingival level that can be a little cumbersome. It really can. And I had a case just this week that the patient was on blood thinners, right? So he was bleeding pretty well. Placed a single cord, and he's still bleeding. And used some hemostatic agent, still bleeding. And so the assistant was like, well, what would you do? And here's what I have found to work very, very consistently over the course of years now. And that is a dual cord technique where I place a 000 first, cut to the exact circumference of the prep itself. So you don't want a little overhang. Then I take a number 2, usually a number 2, whatever the tissue needs in order to get that lateral retraction. I place it. I have them bite into a comper cap, or you could take, and I do not have stock in this company, but this is a comper cap. You could take a cotton roll and cut it in half and have them bite into it vertically, right? It's pressure. Just like if you had a cut on your hand and you're applying pressure, it's pressure. Have them bite into something. Don't have them bite into a cotton roll horizontally. It's not doing anything. It's not touching the gingival tissue. So then like 2 or 3 minutes, then I remove, right before I remove the top cord, I'll put just a drop of water to help prevent the cord sticking to the inside of the sulcus and causing additional hemorrhaging. I remove that top cord. I might use very, very gentle air or a few cotton pellets to just absorb any residual moisture from the sulcus, and I immediately scan, immediately. And the case the other day, it was amazing. I mean, and I said to Brittany, it was even a bridge. I should have taken pictures. I wasn't thinking, but it was such a great example of 1 cord versus 2 cords. Huge, huge difference.
Can confirm. True story.
Cool.
We do have several more questions.
Yeah, let's go.
We've got 2 questions that are pretty similar regarding best way to capture mesial and distal surfaces of surrounding teeth.
The interproximal contact walls.
Mm-hmm.
So if you're in fill tool, and this, maybe I can come up to it a little closer to the camera. Here's my typodont, right? This is the bridge, right? If you're in fill tool, you can come in buccally and angle the wand. Like, think about when you're looking at it in the little viewfinder box, you can zero in on that area before you ever turn your wand on. I encourage you to do that. So get yourself in position, right? The blue hole is encircled in red, and you're going to use your fill tool, and you're going to turn it on, and it will turn tooth colored pretty much right away.
Awesome.
Yes, the 000 with the cord was on the prep itself. So let me just open this up. These are expired, so okay. So this is a comper cap, right? It's cut. This one is for a molar, but you could take a cotton roll and really achieve something very similarly. So you're going to take it, the cord is in place. You're going to take this, you're going to push it into the sulcus. And then of course, this is a partially edentulous opposing. And then you're going to have them bite into it, right? And that's what's causing the pressure. Scan body for implants seem to get in the way of interproximals. Our next session is specific for implants, and we will address that. And in some cases, you will remove the scan body and capture the interproximal walls at that time. What does AI cleanup do? AI cleanup is, AI is artificial intelligence, and the cleanup, well, cleanup or activation? I'm not sure about that question. So AI cleanup can be done through iTero modeling and interpretation. We on our scanners can turn AI on or off. And we used to have to do that pretty routinely for partially or fully edentulous cases. But this latest software grade rather has made that be more automated, be more automatic, and it turns it off automatically. Maybe that's what that was in reference to.
Yes, I believe so. They said enabled and disabled.
Cool.
We did have another question. How do I go back to pick up a missed margin?
How do you go back to pick up a missed margin? So if the margin was missed immediately, you could go back and pick it up immediately, providing the tissue is still in good condition. We spoke earlier, and Brittany showed on the PowerPoint presentation about the difference between, what was it, 5 seconds and 13 seconds, I think. I mean, it's pretty dramatic that moisture can distort the margin at that point. If you didn't realize until now, you could use the eraser tool. So let's say there was something here on the buckle that you wanted to remove, right? There was, let's say there was cord, or there was a tissue tag or something. Notice how it's encircled in red, very similar to like the fill tool. So I could then correct whatever was going on, whatever the error was, and scan that. Now it's in the stone model mode. That's why it's not picking up as tooth color, but, and I would want to make sure I get to the other side as well. Cool. I get a little hesitant about doing this type of technique where you're stitching data on the prep itself. I mean, at the end of the day, it's the scan of the prep that is the most important thing that we're doing next to you cutting the prep. So as far as the scans go, it's the scan of the prep that is the foundation for everything. So in some cases, it may be best to delete it and start again. But this is how you would make a correction. Somebody asked about the green dot and how do you move it? So if you look here, see how it like drags? So I can press on it and drag it. And then to make that like actually stick, I would need to post-process.
Perfect.
Great.
I'm glad we were able to demonstrate that. We do have one last question. If bleeding or moisture contamination cannot be stopped with all the tricks, can air be blown during the image capture to provide a clear tooth image, even though the liquid is in motion?
Yeah. Yeah. And I'm very transparent. I'm very honest about what I have experienced and what worked in my hands. So could you implore four-handed dentistry, right? And have the assistant with the air syringe and like I don't know, a surgical suction, you know, something small, and be doing that and capture the prep? Quite possibly. You really could. You could. I've experienced that before. What I also experience is that in many practices that I'm in, the assistant is doing the scan themselves, right? So four-handed dentistry isn't a luxury for them. I tend not to be a huge fan of error because if you're scanning all by yourself, by the time you air dry and put the air syringe down and then pick up the scanner wand and put it in the patient's mouth, the saliva is back. It pushes it out of the way, but it doesn't keep it out of the way, right? So I always have a 2x2 very lightly clipped to the bib clip so that I can sort of snatch it and stick it right in the patient's mouth to absorb a little more moisture. Isolite, not Isolite because you don't want the light, but Iso Dry works wonderfully well for quadrants. There's Relief, there's hydroformic saliva ejectors, there's other little saliva ejector armamentarium that can be helpful as well. I want to be respectful of everybody's time. I know it's 8:15. I know we've got 2 more sessions. The next session that's already on the books, and I apologize, I don't know what the date is off the top of my head. I don't have my calendar open, is specific to implants. And then we will have a partially and fully edentulous session after that. Thank you for being here tonight. Thank you for your engagement.
The audience, again, thanks for joining us. Take care. Take care of those patients, and don't forget to tell us how we can take care of you.